So our next speaker, it's my pleasure to introduce Bechien Wu. I've known Bechien for over a decade now. Bechien completed his fellowship and started his academic career at the Brigham, where he, under working with Peter Banks and Vikesh, published some very seminal papers in acute pancreatitis severity. And now he is currently in Los Angeles as a partner physician with the Kaiser Permanente group. He also is a clinician investigator with them, as well as the regional research chair, and is currently funded quite extensively in pancreas cancer. So, Bechien.
So I'd like to thank Walter and the organizers for the invitation to speak. I have a very challenging task, which is really to provide an overview of acute pancreatitis. I think made all the more difficult by following Fred Gorelick. And so I'd like to start by tamping down expectations a bit. So I'm going to tell you what this talk is not. It's not a comprehensive discussion regarding the management of acute pancreatitis. It's not a detailed line-by-line assessment of clinical practice guidelines. What I thought would be most helpful would be to give a sort of a 30,000-foot view of some of the key concepts that are currently evolving in the management of acute pancreatitis. And while I have no disclosures, I will give a disclaimer, and that is many of these remarks will be some of my own thinking about acute pancreatitis. When I prepared this talk and was discussing with Walter, I really gave this sense of the type of talk I wanted to give, which would be disruptive, revolutionary. And he said, that's great, wonderful, but you gotta cover the core material. I said, all right, I'll do my best. So with that said, why don't we get started? Let's see. Is it a click? Okay, so first off, some of the core material, I'd like to just touch upon the various guidelines in acute pancreatitis, several of which have been very recently published. Most recently was from the AGA, describing severe and necrotizing pancreatitis. This is really a nice overview, a multidisciplinary piece that describes the management of patients who have complications related to pancreatitis, state-of-the-art thinking there that just came out a few months ago. And then last year, a very thoughtful and evidence-based technical review from the AGA on the initial management of acute pancreatitis. And then the American College of Gastroenterology, the ACG, weighed in 2013 on the management of acute pancreatitis. And then what I thought is what are the core guidelines for international management is the IAP and APA joint evidence-based guideline from 2013, and then also a narrative review from 2013 as well. Most recently, and this is just coming out, I believe it is available online at this point, is a set of quality indicators established by the Acute Pancreatitis Task Force on Quality, supported through the American College of Gastroenterology. And this was really a significant undertaking involving a number of different physicians' perspectives, this iterative process, trying to identify what are the key elements of care that should be measured and quantified in order to improve outcomes for patients with acute pancreatitis. It was a 20-physician panel, 3 rounds of discussions, a modified Delphi process, ultimately leading to 40 quality indicators across 10 different domains. That said, I'd like to turn our attention to this. And this is to remind us that at the core of what we're talking about are the patients. And for a patient with acute pancreatitis, this is a sudden, unexpected, disruptive process, similar to a heart attack or a stroke, seemingly coming out of nowhere. Not only is there this terrible, severe, excruciating pain, but there's also doubt, uncertainty, fear of the unknown. You're being taken into an ambulance, brought up to the emergency department, not sure of whether you're going to have a heart attack or what the doctor's going to tell you in terms of the outlook. So many questions in your mind in addition to the physical manifestations of acute pancreatitis. Now, in turning towards the diagnosis, This is fairly straightforward in terms of a combination of clinical, laboratory, and radiographic features. So typical upper abdominal pain, an amylase or lipase greater than 3 times upper limit of normal, as well as imaging findings of acute pancreatitis. Typically 2 out of the 3 are required. But if you're that patient in the ambulance on your way to the emergency room and you're sitting in the emergency department, the question that I would have is, why is it taking my doctor so long to make this diagnosis? Why am I sitting in pain, waiting for the doctor to come see me and tell me about something's wrong with my pancreas, when in fact, in that ambulance, they've already determined that I have this pain. As soon as you arrive at the emergency department, they're drawing a set of labs and the triage nurse is asking you, do you have this pain? So this is an area I think that is ripe for transformation, where it doesn't really require the physician to interview the patient before we can set in motion the management for acute pancreatitis based on these parameters, which can be determined through machine learning, artificial intelligence, really not even the sort of complicated convolutional networks, but very straightforward automated processes. But what then should be the goals of early assessment? Well, traditionally we've looked at prediction of severity, determining the etiology, administering fluid resuscitation, as well as analgesia or pain management. I put an asterisk next to predicting severity because I'm not sure that's really a priority anymore. And I'll go into that a bit further. In terms of the prognostic scoring systems, there has been, I would say, much blood spilled, much effort spent. It really tried to optimize these clinical prediction systems. And this is a very nice article from Dr. Monzer in 2012 that summarized multiple of these, and we were part of this study, looking at a validation across several different cohorts of the myriad of clinical scoring systems that have been published. And what you'll see is that they essentially have very similar performance characteristics in the moderate range. But I would also ask, how does this change our care and how is this relevant to the patient at the bedside? If our goals are pain management, administering fluid resuscitation, does that really change based on what these scores are? I'd say the jury is still out, and I hopefully would like to convince you that this is really a historical artifact. The one area that I'd like to point out is SIRS, the Systemic Inflammatory Response Syndrome. What's unique about this is that it's a dynamic parameter that can be measured throughout the course of hospitalization and therefore has some relevance in terms of our ability to assess a patient's response to initial therapy. Now turning our attention to etiology. Traditionally, biliary or gallstone as well as alcohol-related etiologies predominate. You'll notice I did not include any percentages here, and that's because it really is going to vary depending on the population that you're caring for. In terms of the additional causes, the one that I would call out is hypertriglyceridemia, that this is something that is, I think, becoming increasingly recognized, and certainly when we're thinking about causes for recurrent acute pancreatitis becomes one of the more common etiologies. If the etiology is initially unclear, then it's important to take a medication history, a family history to consider genetic causes, evaluation of triglycerides, as I mentioned, calcium measurement, and then after the acute episode, consider repeating an ultrasound to look for potentially missed causes of biliary pancreatitis, such as microlithiasis or sludge. Even despite best efforts, the etiology can be elusive in up to 75 or 80% of cases. This was an interesting study from the University of Pittsburgh looking at baseline triglycerides and the risk of organ failure. And I highlight this because what they're showing is that increased levels of triglycerides, even those below what we traditionally think of as hypertriglyceridemic pancreatitis, were associated with increased risk of organ failure. And this gets to thinking maybe it's not just a cause of pancreatitis, but a cofactor in terms of severity, that the presence of elevated triglycerides, even below thresholds traditionally thought to trigger pancreatitis, can be a contributing factor in other causes of pancreatitis, such as gallstone disease or alcohol-related pancreatitis. We found similar findings in our data, but I think one of the challenges has been the amount of missingness, that typically we're not ordering triglycerides unless there's an absence of a clear etiology. I think that needs to change. So we really should be checking the triglyceride levels to understand what role they're playing in modifying the severity of disease. This is a scan from one of my colleagues, actually, a pulmonologist who was referred to me after they failed to really improve following hospital discharge. He's a man in his late 50s, otherwise healthy, had an occasional drink every now and then suffered about what we would call relatively mild gallstone pancreatitis, but was still having issues with difficulty gaining weight following his discharge and continued to experience pain. So we obtained some subsequent imaging, and this is what we call a secretin MRCP. It stimulates the pancreas fluid. It gives us a very nice view of the pancreatic ducts. And what I'll point out to you where the arrow indicates that there was a cutoff of the pancreatic duct, and it appeared somewhat abnormal, ectatic, dilated, something more than what we might expect from someone who just suffered a mild case of gallstone pancreatitis. So we'll refer to him for additional testing, including endoscopic ultrasound, of which he had 2, several images. It just didn't quite look right. We were concerned and ultimately referred him for a Whipple surgery, and turned out he had a 4-centimeter adenocarcinoma. And so I think this drives home the message that in a subset of patients, pancreatic cancer can present as acute pancreatitis. So that's another one of the etiologies to be mindful of. And there was a very nice study from Denmark last year in gastroenterology that reported of patients above the age of 50 with acute pancreatitis. Within the 2-year rate of pancreatic cancer was 0.7% and approached 1% by 5 years. Turning now to fluid resuscitation. This is the dogma when I came up through training, which was really flood your patients with fluid. We're preserving the pancreas. And at the time, it seemed to make sense that, based on some experimental evidence in the late 90s, really impairment in pancreatic microcirculation was some of the earliest changes in acute pancreatitis. That said, we've never had convincing data to show us that aggressive fluid resuscitation leads to better patient outcomes in patients with acute pancreatitis. This is a summary of the randomized controlled trials that have evaluated early fluid resuscitation. And what you can see, the vast majority of these are small studies. The first that I'll highlight was from Mao in China, and they looked at very aggressive fluid resuscitation. The target was to reduce the hematocrit to less than 35% within 48 hours, irrespective of the amount of fluid that was required. What they found was that with this very aggressive volume resuscitation, there was an increased rate of sepsis and mortality. In our trial, where we randomized patients to either early goal-directed therapy or standard care, also layering in lactated ringers or saline in a factorial design, we actually were unable to assess the impact of the rate of fluid resuscitation. And this is a lesson in trial design such that we were undone by a crossover effect, in that the physicians who were caring for our patients in the control arm figured out what was happening in the intervention arm and soon adopted the same practice. So it was a washout. So this is a cautionary tale to any of you who are planning trials in pancreatitis. Meanwhile, James Buxbaum at the University of Southern California, in a trial of mild acute pancreatitis, found that patients who received more aggressive resuscitation had an earlier improvement in clinical recovery. There have since been 2 additional trials, one from Spain and one from Thailand, which have examined the question of lactated rigors versus normal saline, both of which have found improvement in the systemic inflammatory response syndrome. But all of these studies have been underpowered to really address that key question of clinical outcome. The AGA recently weighed in on this and I think had the courage to really state fluid therapy to prevent hypovolemia and organ hyperperfusion is a long established cornerstone of the initial management of acute pancreatitis. However, the evidence basis for fluid therapy in AP is relatively weak. And this is borne out by some of the data from the Apprentice study. I'd like to thank George Papacristo for sharing this slide. And what you can see is that within the initial 12 hours of hospitalization, the amount of fluid resuscitation varies quite considerably. It's all over the map. And to be frank, we don't have a real sense for which of these is the right answer. But at the end of the day, what it boils down to is this concept known as the Bellamy curve, which is on the horizontal axis looking at the amount of intravenous fluid volume, and on the vertical axis, the rate of complications. And you can see there is this optimal window. And that's going to vary based on patient, based on the phase of illness, and based on the amount of volumes, intravascular volume status. This is an area that I think is ripe for, again, augmented intervention. And by that, I mean this revolution that we're seeing in terms of precision medicine and personalized care. And how does that look? Well, we certainly have advancements in biometrics where we're able to get instant real-time feedback in terms of the volume status of a patient, and that can give automated feedback into algorithms for determining what is the optimal fluid resuscitation for that individual patient rather than these one-size-fits-all strategies. Turning our attention to analgesia and baseline opioid use, the point of this slide is not to pick out these individual dots, but to show you that, again, it's all over the map. And by that, I mean, what are the factors that drive the amount of opioids given in the first 12 hours? This is something we studied with our population. And what you can see, I mean, what's reassuring, this square way out to the right, that's the maximum pain score. That really makes sense, that probably the pain should drive the amount of opioids that are being used. But interestingly, SIRS was also a significant factor. In addition, there were non-clinical factors such as age, sex, also race, ethnicity, such that African Americans, Hispanics, as well as Asians received less opioids compared to non-Hispanic whites. That's after adjusting for all of these additional parameters. And one wonders, is that a patient-based factor or is that potentially a bias based on the provider? I think there need to be more trials such as this, which was from India, looking at the effect of pentazocine versus diclofenac, a relatively small study, but really trying to optimize and standardize our pain management strategies. So now our patient is on day 2. They're lying in bed and they're asking us, am I getting better? Can I eat? When can I go home? How are we going to assess this condition? And this is an activity scoring system that was recently developed. And I think rather than focusing on the weights and the actual calculation of the score, it's important to look at what were the parameters that were identified through this panel of international experts. There was organ failure, tolerance of a diet, SIRS, as I mentioned, abdominal pain, as well as the morphine requirement. Also, most important that I think needs to enter the discussion are patient-reported outcome measures. And this is something that's been highlighted in several different forums that have recently been held in terms of drug development in acute pancreatitis. There's a study that was recently concluded in Spain to try to investigate the patient-reported outcomes. And I think this is an area that will help inform us moving forward about what are the targets we really need to reach in terms of care. For nutrition, I'll just comment that traditionally, we've thought of enteral nutrition through a feeding tube, leading to better outcomes in severe acute pancreatitis. I'll just point out that that's the vast minority of patients. In the vast majority of patients, oral refeeding is what is going to be most important, and optimizing the time of oral refeeding is really going to be the beneficial to the care of our patients. Along these lines, there's a movement in surgery, enhanced recovery after surgery. This is a slide from the National Health Service in the UK. It really embraces the concept of engaging the patient to be a partner in their recovery, and also early refeeding, euvolemia, and multimodal analgesia to try to minimize the harmful effects of opioids. This is something that I think we can bring to the care, to the bedside for patients with acute pancreatitis as well. We tried to incorporate some of these elements in a pilot randomized control trial. One of the key aspects was allowing patients to determine when it was right for them to eat. It was patient-directed oral refeeding, and what we found was that many patients often began their diet much sooner than traditional care pathways, and that there was no evidence of failure to lead to complications with this approach. Something that needs to be explored further. One other point here is additional stakeholders. An interesting caveat from the trial that we performed in Enhanced Recovery was that patients felt that during their hospital stay, the ones that were targeted to enhance recovery, even though they received less opioids, felt that they had their pain better addressed and the care management team was doing everything they could to address their pain. This is important for stakeholders, for payers, as well as hospital administrators to understand the satisfaction with care. And a lot of this really has nothing to do with the amount of pain medicines that are administered, but rather the communication with the patients over their pain management plan. Finally, I'll turn attention in just a brief few moments on complications of acute pancreatitis. This is an example of what we call walled-off pancreatic necrosis. You can see a collection here with some solid material within it. We'll often receive questions from our colleagues, how should I manage this patient? Should we start with a drain? Should we refer them to surgery? And my response is, well, how is the patient doing? And that's really the key concept here, is that we don't want to be treating a scan, rather the patient before us. And if this patient is not having fevers, there's no pain, and they're interested in starting a diet, by all means, we should go ahead and allow them to eat and try to get them on their feet and home. This is not necessarily something that needs treatment unless it's showing us signs of significant clinical impact, such as fevers or abdominal pain, in which case we have evidence that shows us a minimally invasive approach is superior to open neck resectomy, something that was shown in the Step Up trial, a landmark study from the New England Journal almost a decade ago. Finally, I would be remiss if I didn't point out that another key component to this, to care of patients with acute pancreatitis, is prevention. And so when someone is in the hospital, it provides an opportunity to really intervene to prevent future recurrences. And some clear data has come from the Dutch Pancreatitis Study Group. The Netherlands has really been a valuable resource in providing us greater evidence in how we care for patients. And in this study, they looked at early cholecystectomy for gallstone pancreatitis, removing the gallbladder within 3 days of their discharge versus deferring this to allow the inflammation to subside further. And what they found was that there's a dramatic reduction in the rate of recurrent episodes of acute pancreatitis, as well as biliary complications with the early intervention approach. So just to wrap up, some key points for early management. We want to identify the etiology because yes, that does impact our management and care pathways. Moderate fluid resuscitation or euvolemia should be the goal until we have other data that suggests otherwise. Mixed modality analgesia, early ambulation, and patient-directed oral intake are the directions for care. And in terms of complications and prevention, minimally invasive approaches have shown to be superior than open surgery. Nutritional support is key, and often that means feeding by mouth, using the gut whenever possible. And then prevention strategies directed towards etiology. Thank you for your time.